How's your week been, man?
Good, thanks, boss. Very good, very good. A lot less stress on my shoulders now that I've completed that sport dietitian course through Sport Dietitians
Nice.
Australia.
Congratulations.
It's a really, really interesting course. I highly recommend it to other dietitians out in the field. But if people aren't in the dietetics field already, sucks to be you, aren't able to access. So come and have a chat with me. I very much love to have a chat with other allied health professionals, people in the industry looking to kind of upskill and increase their total knowledge around that kind of area, but looking to incorporate some more athletic oriented individuals and more so elite athletes into the future of R.E.A.L. So kind of delving into a little bit of your area there, Max.
100%, man. I think it's awesome. I think it's awesome the fact that you've been able to get into these areas where you necessarily weren't super confident in them, and you've been able to gain so much knowledge. And I think the IBS one, doing that course you did through Monash, incredible as well. You know, it's given you the option to be certified, so it gives you an actual certificate to say that you've done this course. You are at an expected level of understanding and knowledge, which is incredible, as well as you just know your stuff in general, which is awesome. But
it's so
I think it's really
rewarding.
cool.
Yeah, absolutely. It's so rewarding being able to actually have a chat with clients and work through their specific situations and actually get them to results where they never thought they would ever be able to feel quote unquote normal, which is just like such a great experience. But that's absolutely a really good point to mention is, okay, looking for confidence gaps and areas of knowledge that I'm not necessarily around. Sport nutrition, I have a massive interest in it, but I'm very much aware that my knowledge of endurance sports prior to the sports dietitian course was pretty mediocre. I would say it's probably on par with like a general kind of leisure sport activity individual. Now I'm quite confident in that area, which is really great. So in terms of my progression through that specific instance, sports dietitian accreditation was really cool. That was probably the next one on the list. Before that, exactly like you mentioned, the IBS FODMAP run by Monash University, supporting people through IBS tends to be a little bit more common nowadays. Now that it's not just like, hey, you've got some weird thing going on with your stomach. No, you can have a specific condition that has treatment modalities available for it. And then prior to that, throughout my normal nutrition bachelor's and my master's of dietetics practice, I wanted to focus on diabetes. It's such an interesting area of healthcare, and we're kind of in a diabetopocalypse at the moment where the rates of diabetes are going through the roof. It was such an interesting thing, but I felt like everyone around me just didn't understand it. I was like, what do you actually, how do you diabetes? It didn't make sense to a lot of individuals around me. Conversations I had would contradict each other, even among some dietitians, which I thought was appalling, considering it's probably one of the main things that we see as dietetics. I probably see maybe 40% of my clientele tend to be type 2 diabetics. So ensuring that I can deliver a very good service that provides them a pathway that works towards their goals is incredibly important to me. I think I'd like to talk about that today, if that's okay, Max.
Yeah, man, 100%. Yeah, look, I'm crazy. You already ran it through me that you wanted to speak about that today. And yeah, I think, man, it's awesome that you are able to identify that. And I think the biggest thing that I've listened to quite a few people that I don't usually listen to on this sphere of maybe a little bit less orthodox science based, if that makes sense. Like they're a bit like unorthodox, bit like on the outer edges. And the biggest thing they kind of focus on and grab hold of is this whole idea of like holistic health and focusing on like metabolic health outcomes rather than specifically just pills and all that. And I think the problem with that is that because they've kind of owned that space now, like in the sense like they want people to stop taking pills and just get healthier by eating more vegetables, exercising more, focusing on your mental health, then what that's done, in my opinion, and you can tell me if you think I'm wrong, but because they've taken that space, then almost because the people which are like in the more orthodox science field, so like I guess you'd say like people like me and you, then people see they're doing that and they go, oh, well, I don't want to be associated with them, so I'm going to go even more down the route of, pills and drugs are the only way. Whereas I think, am I making sense?
Yeah, so more so that like there's a bit of a dichotomy between the extremes of like, oh, you cannot touch any medication versus people who are obsessed with medication, and medication is the only way to address these kind of situations. But then when we sit very firmly in the middle, I think.
100%. Yeah, exactly. Yeah. And I think both sides strawman each other in the sense that the side of the people that are only about holistic are like, well, all doctors do is they just they just prescribe, and it's big pharma that's causing all this, and blah, 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 and they go into their conspiracies. And then the other side, the doctor's like, well, they just drink herbal tea and they don't actually do anything that, it has any sort of validity. And it's like, well, we've studied herbal tea and we've shown that it has no impact on health markers and all sort of stuff. So both sides really strawman each other a lot, and they're both very valuable, despite one of them being, objectively less science-based. Telling people to stop eating, trans fats and burgers and, just custard for 99% of your liquid intake is a good thing. And moving them away from that is just objectively a good thing. So both sides have their validity. And, what I heard from that was they were talking about, these people were talking about metabolic health. And they were saying like in the 1950s or 60s, there was, I think 1% of very short time ago, 1% of the ratio between type 1 versus type 2 diabetes was 99-1.
Wow.
And now it's like, something insane.
Just to clarify for the listener, 99% of diabetics being type 1 versus type 2, which is probably almost the complete opposite now. I'd say 99% are type 2 diabetics. And so we're clear, type 2 diabetes is the one that you generally get throughout life from, let's say, a lifestyle that doesn't really work towards your overall health. And then type 1 is more of the genetic type, where it's earlier on, kind of childhood onset, similar mechanisms, but different in terms of their management.
Yeah. And just to make things a little bit clearer for the audience as well, and this could be really taken out of context, so you could literally clip it now and I'd seem like I'm someone that's not very maybe polite or like empathizing, but essentially type 1's the one out of your control. You got nothing you can do to decide whether you get type 1 or type 2, and type 2 is the one that's more within your control, or there's factors that are within your control that aren't purely genetic. Obviously, there is a big genetic component to it, but it's not purely genetic in the sense that if you have a high proclivity to get type 2 diabetes, that doesn't mean you necessarily will 100% get type 2 diabetes. Whereas if you're going to get type 1 diabetes, you're going to get type 1 diabetes. It doesn't matter what you do.
Absolutely.
Is that
not
overall?
To say, yeah. So yeah, I 100% agree with you, but not to say that you can't manage the type 1 diabetes through lifestyle factors. Because I think you absolutely can. I think that's across both the situations, that lifestyle factors, recovery, exercise, nutrition absolutely have huge factors in these kind of situations. Probably more so for the prevention of type 2 diabetes and more the management of type 1 diabetes. I feel like there's a lot of words going around. If someone who's not familiar with this field maybe a bit bamboozled with all the type 1, type 2 nonsense. For this kind of conversation, we're going to be specifically talking about type 2, which is predominantly the one that you kind of acquire through life, through some lifestyle factors that aren't necessarily beneficial for your health overall. So a higher total, this is probably a little bit more controversial, higher total, high GI carbohydrate intake paired with inactivity, paired with obesity, and paired with other comorbidities generally provides an environment where type 2 diabetes becomes a lot more prevalent. And we're seeing the rise in type 2 diabetes skyrocket through the roof with the same rise in obesity rates.
Yeah, and I think the whole element of, I don't know the numbers of what it is at now, but the whole element of the fact that we've seen such a insane rise in type 2 over the last few decades, and the fact that, that, as you said, Matt, that 99-1 has basically flipped. It's not that dramatic. It's not like it isn't 99-1, but it's significantly, I think it's the vast majority of diabetes cases are type 2 diabetes now. Just shows that, we've got there's a serious problem, and type 2 diabetes is no joke. It's do you know the stats off the top of your head of how much it reduces your lifespan on average, Matt?
I had some stats recently. I'm probably going to butcher this statement. I recently did a bit of a webinar run by a really amazing dietitian, which her name escapes me at this point, but she's based in Sydney. Both an exercise physiologist and a dietitian, which I think is a great combination. Not really applicable as much now. So she did the dietitian course when it was still a bachelor's. So it's a little bit more complicated with us doing that. Plus Hexstat is a bit of a no thank you. So in terms of the statistics, I think the 5-year survival rate for type 2 diabetics on the onset of diagnosis is like 50%. Which I think is absolutely ridiculous.
I guess there's a lot of people that get diagnosed late in.
Absolutely, absolutely. The age of diagnosis is skewing that data. But on average, if you were to kind of say, okay, when you have type 2 diabetes, it's been a long time coming. It's probably something that's been pre-diabetic for an extended period of time. Plus, that's kind of that point where our general health tends to spiral downwards if we're not paying attention and if we're not caring about how we're treating our bodies, how we're managing our own health. It can be quite scary. So for early onset diabetes, it's a massive red flag. Like, wait, look, shit's going fucking wrong. We need to manage the situation right now. For later onset diabetes, probably more to with the 80s and kind of late 70s situation, it's probably going to be a progressive thing. Generally, a reduction in total activity comes along, reduction in total muscle mass, insulin resistance. A lot of these buzzwords can often be, let's say, kind of thrown around as like, oh, they're all blah, 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 blah things, but they're actual medical terms that we're generally referring to. And these kind of situations do apply to a lot of individuals. Both situations are very serious. Both situations have a multiple range of side effects and implications. The way you manage both is incredibly important as well. So it's similar management. Max, do you have any comments on that?
Yeah. Well, I think I'd love to delve into the slight variations in management as well that you're going to get. But I think firstly, let's cover, because this is a really good foundation to cover, I think, and then we can kind of bounce off there. You said there's three important factors that are pretty much ubiquitous to developing type 2 diabetes. And you said it as well, and I know you think this because we've spoken about this a lot, they also need to be simultaneously together. So in the sense that you said obesity was one of them, you said inactivity was another one, and lots of high GI carbs, did you?
Yeah, excessive high GI carbohydrate intake.
Yeah. So let's have a chat about that, because I think that's really interesting in my opinion, and it's a really good to illustrate to people how we can have certain populations which only meet 2 out of the 3, or that are still very unlikely to develop type 2 diabetes. That one being sumo wrestlers.
Yeah, a really, really interesting population.
Can you take us through that? Yeah.
Absolutely. Yeah. Absolutely. So we've probably talked about this on the cast previously, and I should probably start this conversation with, for people who aren't familiar with diabetes, what it actually is. So type 2 diabetes is when your blood glucose levels, also known as your blood sugar, but more specifically blood glucose, is elevated past, let's say, a certain threshold. It ranges depending on which country you use and which measurements. In Australia, I think it's a 7 milli. I'm going to butcher the measurement unit. When it gets past a certain threshold, the level of damage that starts to occur to the rest of the body's cells, your sensitive tissues, tends to kind of exponentially increase. And generally, that means that the glucose from your bloodstream, which we need for energy, there was always glucose in your bloodstream. Otherwise, you die within like 5 minutes. It's pretty quick. The glucose in your bloodstream does not efficiently transfer and move into your cells, your organs, your muscles, all the stuff that needs energy. So that can generally kind of cause a few different problems, as well as there's a few different mechanisms of how this happens. But for the simplicity of this conversation, type 2 diabetes is a chronically elevated, which means elevated over an extended period of time, level of blood glucose.
Guys, quick ad break. We are currently taking on clients. Click the first link in the description to explore more. Back to it.
Full stop. So that means
that's about
blood sugar elevated over a long time. Causes problems, massive pickles.
And so you'll hear words like buzzwords like insulin resistance and things like that. And it all falls under the same bracket of the fact that the insulin is it a hormone? Yeah, it's a hormone our body uses. The insulin is a hormone that our body uses to shuttle in the carbohydrates into the cell so that it can be utilized. And if you're resistant to that, then the carbohydrate cannot be shuttled in as effectively. So that's why there's those buzzwords like insulin resistance. But literally for 99% of the cases, if all you know about it is the sense that exactly what Matthew just said, which is elevated blood glucose levels, that's all you need to know. And if you think of blood glucose as blood sugar, if you even want to make it even more simple, that's absolutely fine as well. That's a good way to think about it too.
Yeah, absolutely. So the overcomplication can be quite tricky in some instances.
Exactly, and especially when you don't need to as well. There's no reason to overcomplicate this. It's quite a simple area, I guess. Like it's quite a simple way to understand it, and then you can build it from there if you want. I think a little just a side note, or just steps to the side. The best way to explain this to people is once you have that foundation understanding, then you can really just bounce off that to think about artificial sweeteners and like your stevias and all that. For when people go, oh, but it still spikes your blood glucose and you have insulin, so you're going to produce fat. It's like, well,
so many holes in that statement.
Yeah, because if your insulin went through the roof, then you would become extremely
hypoglycemic. Yeah, so the blood sugar would go too low, and then there wouldn't be enough total available glucose in your bloodstream, which means that cells will starve of energy. You tend to have problems very quickly. One of the main key important factors that need a lot of glucose is both your brain and your heart. Once those start to run out, shit starts to turn off. You die pretty quickly. I think once it falls below, I think it's like a 3.5 or so, tends to get pretty dicey in terms of, hey, you're not doing too well. If insulin had spiked when you had some artificial sweeteners, man, we would see so many people die on a daily basis. It's just like,
exactly, 100%. And because the reality is you can't use in the artificial sweeteners, you can't use the energy that's available in them. That's like essentially the way the whole thing works. So it's not providing you with any carbohydrates. And then if your insulin was to spike, you would only be able to use the carbohydrates that are floating around in your blood. Like normal, your blood glucose would drop super low and you die. So that's a really good way to kind of explain in a myth, longer way. Like if you've got someone that's really pushing back on that, because sometimes I get that. Sometimes I'll have clients, pretty rarely, but they'll push back really hard on that. They think artificial sweeteners are the worst than cancer, all that sort of stuff. And it stems from like lots of things, usually just preconceived notions that artificial sweeteners have to be bad. I think it's because, and tell me if I'm wrong, Matt, but I think lots of people, we live in a world where it almost seems like you get nothing for free. There's always trade-offs to everything. If you have something tastes good, it's got to be bad for you, or it's got to be fattening, or it's got to be, where it's like almost opposite. If something tastes bad, man, it's got to be good for you, right? Like even if you didn't know chocolate wasn't the most positive health outcome food in the world, but it tasted really bad, most people would probably be like, man, this has got to be good for you, bro. If it tastes bad, absolutely, it's got to be good.
The placebo effect will absolutely come into effect.
Yeah. And I feel like that's kind of the case with artificial sweeteners, because it tastes good. It's like sugar. It's like, and then you say, well, it doesn't really have anything that's too bad.
Sugar's bad for me. So like, that means artificial sweetener, anything sweet is bad for me. Yeah. And then you can go down the whole like dopaminergic pathway where it's like, oh, dopamine's bad for you. And then you have to do like dopamine detoxes. That's a whole nother kettle of absolute.
Yeah.
No. But
so that is cool. It's a lot easier to explain it on a whiteboard because you can kind of show the whole pathways and everything. But anyway, that was just a little sidetrack. Amazing explanation of diabetes. Can you kind of explain type 1 versus type 2 to us as well, just really quick?
Yeah, absolutely. So the main difference between type 1 and type 2, so for what people are thinking of, type 2 is generally the one that we acquire through life, just so we're absolutely clear. Type 1 is you have a genetic predisposition. It's in your family history, most likely. You generally get it when you're very young, usually during your childhood. Type 1 is when you have an autoimmune disease and your immune system attacks your pancreatic beta cells, which are the cells that produce insulin. That was a lot of words. That means that you don't produce insulin anymore. What does insulin do, as we discussed earlier? Insulin is the signal. It's the hormone. It's the one that knocks on your cell door that says, oi, let the glucose in. I need to come inside. When you don't produce that insulin, your blood glucose rises too far because, of course, we consume food. We make glucose from other things. So just so you know, we also make glucose from fats and from proteins, just at a reduced rate. So we always have a baseline level of glucose in our body. When there's no insulin there, there's no signal for the cells to open up and accept that glucose. It stays in our bloodstream way too high. That's type 1. Type 2 is when we don't produce enough insulin. Our production of insulin can reduce, as well as our cells don't accept the same level of signal. So when insulin rocks up and says, hey, open up, I need to come inside with the blood glucose, I need to get the sugar, the carbohydrates into your cells, your cells will be like, no thanks. Then you need multiple units of insulin for the same level of response to let that glucose come into the cell. And when you get later and later down in severity of type 2 diabetes, then it's almost indistinguishable between type 1 and type 2, because it gets to a point where your pancreatic beta cells are pretty much all completely shut down. They're gone. And then you're basically not producing any insulin. So type 1s always need to have an insulin injection, whether through a pump or through previous methods being through needles, which is very difficult like 20, 30 years ago. Pumps are a lot more efficient nowadays. It's really, really amazing in terms of the progress that we've made with type 1 diabetes management. When type 2 gets really severe, it's almost a similar level of management where insulin needs to be provided on a weekly or potentially daily or even hourly basis, which can be very tricky and very scary for some people. Look, then you get into a hospital situation and it gets even crazier, but we'll stick with the general population for now.
Yeah, for sure. And yeah, so I think there's some similarities and some differences here. And I think the similarities is that on the early stages of both of these, they look very similar in the sense that on the early stages of type 1, your body hasn't attacked all the pancreatic beta cells, so the cells that produce the insulin. And you're kind of in this transitional phase between you're not solely on insulin just yet, in the sense that your body's producing a little bit and you're providing a little bit. And then as time goes on and the autoimmune disorder destroys all of the beta cells, then you eventually transition to solely being reliant on the insulin. And the same goes for type 2 in the sense that one thing that you just missed out, just in case people weren't fully understanding, when those pancreatic beta cells are working a lot, as Matthew was saying, as you become more and more resistant and you need to start producing more and more insulin to get the same result of shuttling into the cells, they eventually die off. And the problem is that it's like a bit of a positive feedback loop there, Matthew, in the sense that the problem is that you need to produce, like, let's say when you were 30, you needed to produce, I'm just going to use like easy to understand units, even though this is going to be completely wrong. You need to produce 10 grams of, you know what I mean? Like this is
sure. Yeah.
When you were 30 and you'd eat a sandwich, you need to produce 10 grams of insulin to shuttle that all into the cell and utilize the carbohydrates from the sandwich. And then by the time you get to 40, you need to do 20 grams and then 30 grams when you're 50 of insulin. And the problem is because, and that's just due to the insulin resistance. And what happens is as they work more and more, now if you by the time you're 50, you only have 70% of the beta cells working now. Not only do you have to produce more insulin, but you have less cells to actually produce it. So it just gets worse. It's compounding, right? Like then you need to produce even more insulin. You've got even less, and like very quickly, you've got lots of beta cells dying. And you have that similar transitional phase where you are relying a little bit on the exogenous insulin versus the endogenous insulin. I like to think of the insulin like when you go to a fancy restaurant and the waiter brings you to your table.
Oh, that's a great one. To your table. That's really good.
Like the waiter greets you at the door. Hello, sir. Table for two, please. No worries. Let me show you to your table. And the waiter takes you from outside the restaurant, from outside the cell, brings you in, lets you in the door, takes you to your seat. And then, for some reason, all the fancy restaurants I've been, that's not like they walk you out. You walk yourself out. And kind of the same goes for carbohydrates. Like they don't get taken back out. They just kind of chill there.
Well, they chill there and they get used up. So that like you go through the experience,
exactly.
You go through the process of being used as a carbohydrate, even though you're a carbohydrate in this instance. And then that's like we use that for energy. So we need that for our body's general functions. Hence why exercise is so important. We're going to go down that route in a minute. But that's a really great analogy. It's much better than the bouncer one. I think the bouncer one's a bit meh.
Yeah, and well, I literally thought of it then while you were speaking. I was like, what analogy could I think of? And then another analogy I could think of, which is an amazing transition. I'm so proud of myself right now. Amazing transition to what we actually wanted to speak about today, which is reversing type 2 diabetes. If you're a bit struggling between type 1 and type 2, that can happen with some people. They just can't remember which one's which one. You could potentially think of type 1 as being one and done, in the sense that once you get type 1, you're done. Like, ain't nobody reversing that for you ever. That's just one and done, baby. And then 2, not so much, in the sense that there are things that can alleviate your situation, because it's not an autoimmune disorder attacking your system. It's almost a little bit self-inflicted in ways. And there's a lot of debate, controversy, a lot of people talking smack, people talking truth around type 2 diabetes and reversing it. We've changed our minds probably 20 times on this, I reckon, Matthew. Take us through what we think on it, what you think on it, all that.
Yeah, we went down the rabbit hole. So we originally thought, okay, look, it's just simply that carbohydrate intake is too high, and then why don't we just go through a different pathway? Why don't we just give everybody fructose? Because fructose is processed by the liver, it's not going to raise your blood glucose nearly as much. That will kind of fix the problem. So we replace everyone's standard sucrose, being one glucose and one fructose molecule. We get rid of the glucose, we just have just fructose. And then we kind of went down that pathway. It's like, no, generally doesn't work. There's a lot of different factors in that scenario. It's not just the fructose. And then you kind of just encouraging the wrong thing. So why would you encourage additional energy intake versus encourage potentially an energy deficit and more nutritious foods and exercise and activity and recovery and adequate distribution of carbohydrates throughout the day, which tend to be a bit more of a priority? Then we went down the rabbit hole of, okay, well, that's simple. It's just carbohydrates that cause it. Not necessarily. You can still be insulin resistant with a low level of carbohydrate intake. It's just that the symptoms aren't going to be present because you're not inducing or consuming exogenous carbohydrates through food. Then it's like, okay, cool. So carbohydrate solely isn't the problem. How do we progress and understand this condition better? It must be one single cause. And with everything, there's never one single thing that leads to, it's not X equals Z. It's X plus Y and maybe Z might equal XYZ later down the line. There's different situations that happen with type 2 diabetes and an environment that needs to occur to generally bring it along. Generally, exactly like you mentioned, Max, you need to have inactivity, so an inadequate exercise. You need to have excess carbohydrate intake, potentially inadequate distribution, and a potentially higher GI, so the spike of blood glucose quicker. And you generally need to be of the more overweight variety. But then this one's probably a little bit more controversial because, again, exactly like you mentioned before, Max, sumo wrestlers. They're such an interesting population. Would you like to have a discussion
There's
on
many
that one?
interesting populations, actually.
Yeah, absolutely. Absolutely.
Yeah.
I'll have a chat about sumos. Would you like to take away with the rest in a second?
Let's do it. Let's dive into sumos, and then we can kind of go from there. Because I think sumos, whilst it might seem like, oh, well, I'm not a sumo wrestler, like, what's this to me? It's a really good example of that. One, you need to be ticking all three, pretty much need to be ticking all three boxes in order to develop or have a much higher chance of developing type 2 diabetes. And two, if you're in a situation of, man, like I've got to change, I've got to lose weight, I've got to completely change my diet pattern, and I've got to start exercising. Like that is three really, really big things to do in your life. Oh, well, let's start by doing like half of one or like one, and then see how you feel after that kind of thing. You know, because even that can be a really, really big game changer for something like type 2.
Absolutely. So with sumos in particular,
sumo.
Yeah, we kind of went down like the healthy at every size rabbit hole. Can you be healthy at every size? Listen to our previous podcast to find out if you can or not. So to kind of dumb down why we don't see sumo wrestlers getting a lot of type 2 diabetes at what we would expect for the same level of obesity is that they have a lot of muscle, like a lot of muscle. They have so much muscle where if you compare myself to them, I would say I'm fairly musculature, definitely above like your average person, not necessarily the average person that goes to the gym, but your average general population individual. You compare my total lean muscle mass to a sumo wrestlers, you're not even comparable. They're absolutely insane in terms of the total muscle. Their training ethic is absolutely incredible, but you don't really see the same level of type 2 diabetes occurrence because of that muscle. That's generally the one major variable that is different between those two situations. Muscle itself is incredibly insulin sensitive. It just accepts insulin, and if you have insulin there, it shuttles the carbohydrate straight into your muscle, shuttles the blood glucose straight into your muscle. So that's an instance of it doesn't have all three, and there's an excess amount of muscle there providing a positive health stimulus where it's negating some of the potential negative effects from obesity and things along those lines. I would almost argue that the total amount of muscle mass is probably more important than being overweight in the first place. That's a little bit more of a tricky situation. I need a little bit of data to support me on that one. Then again, sumo wrestlers still have similar problems with hypertension, blood pressure, because generally when you're a bigger person in a bigger body, it doesn't matter if it's muscle or if it's adipose tissue, you're going to have blood pressure problems most likely. So that's an interesting factor to have. So that's something that if you're really passionate about, and probably why we see more type 2 diabetes development later on in life in some individuals, is that when we kind of age, our rate of muscle atrophy, the rate our muscle breaks down increases. So we lose muscle quicker between stimulus points. So if we're not exercising very often, the rate of muscle loss kind of moves quicker.
Yeah.
The more muscle that you lose, the more insulin resistant you become, which means the less insulin sensitive, which means that blood glucose and blood sugar rises in your bloodstream more quickly, and it stays elevated because it doesn't have the same level of insulin receptivity. It doesn't acknowledge the same level of insulin to shuttle that glucose into your cells where it's needed. And that's probably what we more so see with like the 70s, the 80s, where we're starting to see a functional decline. We're starting to see potentially a reduction in overall physical capacity, reduction in physical ability. And we're seeing blood glucose rise alongside that because, of course, you're not providing a stimulus for the muscle to grow. You're not providing a stimulus for the insulin to be accepted. And the blood glucose just tends to rise, which I think is a really interesting position. And if more people were aware of this, then I think it would probably reshape the entire kind of mantra of how we address and support elderly care.
Yeah, man. Yeah. I think the biggest thing with all this, and almost the theme for this podcast, is the best thing and the worst thing about all this is that it runs off positive feedback loops, in the sense that the more muscle you have, that's amazing because it just branches off so many things. It probably means you're also a lot more active, and active muscle just chews through glucose like crazy. It stores glucose really well and it chews through it like crazy, and it just means your management of your glucose levels in your body is going to be so much better, especially active muscle. You can think of it like just a glucose garbage truck, really. It just chews it up and spits it out super easy, especially and then so that thing. And then it's like, well, then when you start to lose muscle, just like you were saying, it's like then all the bad things just compound like crazy. You've got less muscle to store the glucose, probably less active, which means you're using less glucose, and then everything just gets worse and worse and worse. And then your blood glucose levels rise, which means that you get more damage of your cells, and like everything just like compounds and it just gets worse. So it's like the good thing is that if you do take these steps to improve your blood glucose and all that, it can actually be a really good thing, because it can mean that you are compounding your way out of this. But then if you stop that, it really starts to impact it negatively. But I think the sumo wrestlers is super interesting because they eat a lot of food, a lot of carbohydrates. They're very, very overweight, but they're due to the activity levels and the muscle mass levels, super low rates of type 2 diabetes.
In comparison to a population that would be similar body composition with a lower muscle mass.
Yeah, of course.
Yeah.
Yes, for sure.
Max, I had an interesting conversation, just to kind of branch off because my brain won't let this one die down. I had an interesting conversation with a healthcare professional recently about their thoughts on type 2 diabetes and pancreatic, let's say, burnout, how the cells, quote unquote, burn out over time. I think that's pretty feasible for that to occur. And we're noticing that the cells generally, they die once the insulin starts to be overproduced. Could you run through me maybe a kind of a counter argument? Could you play devil's advocate to see if there isn't potentially a reason for that?
I don't think I could, no. It just depends how simplistic you want to look at things. You could look at things like super simplistic and be like, well, why is it that when the kidneys get really overworked, they die and the nephrons die? But then when you work your heart really hard and you go for a run and that works really hard, that's actually good for your heart. It's like, okay, like, is that really what we're dealing with here? Like are we dealing with people that like working everything really hard is a good thing, a blanket rule? It's like, dude, we just don't work off blanket rules of like working something hard is a good thing or working something not hard is a good thing, because then you just going for a run would be like the most awful thing because you're working your heart really hard. So no, I think it's just super obvious to me. There's evidence of it. The fact that the cells die, like I haven't looked into it really thoroughly, so I couldn't like explain to you exactly what it is, but I know it's a thing.
My assumption was that with the higher level of energy required to produce the insulin, that the cells generally just die from energy starvation, is what my main thought process was. Again,
I thought it was
I've got nothing to
inflammation.
back this one. Yeah, absolutely. There's definitely a level
Yeah.
of inflammation that occurs in that situation. A reactive oxygen
Yeah.
species just occurring and damaging cells.
Yeah, that, and also the visceral fat massively. Like those two things.
Yeah, absolutely.
Big ones. Yeah.
The visceral fat being interesting because it potentially reduces the amount of total circulation to that area and the provision of nutrients in it's definitely an interesting position. We do see increased rates of visceral fat around the pancreas with type 2 diabetic clients, which I think is potentially a huge contributing factor in the scenario. Hence why obesity is such a potentially a bigger factor in this whole situation.
Yeah, I think it is, and I think it's a bigger factor than what people would probably like to admit.
Yeah.
Because it sounds a bit harsh, to be honest. You know, like it's a lot easier to go, well, you know, it only comes down to your diet, or it only comes down to exercise. But I think the reality is, in my opinion, is that, and I think probably literature support this. I haven't looked at it, but yeah, probably that it's massively your weight as well. It's a big one.
Yeah, look, it absolutely is, but it's not the only factor. I think that's what people get caught up with. It's like if you lose weight, the type of diabetes may not go away because you potentially may hinder your total muscle and lean mass position. So that might be even 100%. Worse than this. Like if you jump on Ozempic, and if you take, well, Ozempic also produces a high insulin sensitivity, so that's a different story.
Yeah,
but let's say
tricky,
you go on Ozempic, you lose the weight, you go off of Ozempic, your blood glucose rises like crazy because you don't have the same level of insulin sensitivity as before. You're just in a shit position overall. Like it's kind of setting you up to fail. It's very tricky. If you're not providing those really positive habitual routines with the Ozempic or the GLP-1 agonists during that period of time that you're on them, it can just set you up for a really tricky spot later on.
Yeah, 100%. And I think the problem is for me and my gut inkling with all this, I doubt there'd be any research on this just because it's so niche, but I bet you people that have spent a long time, 1, 2 more decades sitting in that space of extremely inactive, extremely low levels of muscle mass, high BMIs, and what was the other one?
Inactivity. Okay, yeah, inactivity, high BMI, excess carbohydrate intake with high GI
and excess carbohydrate intake. I bet you when you've been in a space where you've sat in that for multiple decades at a time, because remember, this stuff doesn't happen overnight. You don't just have a couple of bad weeks where you do those 3 things and you develop type 2 diabetes. It happens over decades. And my personal guess would be that if you've sat in that space for a couple of decades and then you do just happen to get yourself down, like you happen to lose a lot of weight, go on Jenny Craig or whatever it is and lose a bunch of weight.
You go see a dietitian, you go see Max, you go see Matt. Yeah.
And yeah, you lose, well, you might do it in a way that's less sort of what we would recommend. And you just lose a ton of weight. Still super inactive, still super low levels of muscle mass, and still eating relatively high carbohydrate foods-ish. My inkling is that because you've damaged your body and your cells for so long, you're not at that regular stage now where it's like, well, because the average person, the reality is, Matt, and I'm sure you'd agree with me, the average person is, as long as, even if you are inactive, have low levels of muscle mass and eating a lot of carbs, if you're not obese, the chance of you getting type 2 is probably still extremely low. But the problem would be is if you did get down to that phase where you're only ticking 2 out of the 3 boxes after decades of sitting at a high BMI as well, because you've damaged those cells so much, I'd say, just like you were saying before, if all you did was lose weight, you're probably still not going to be in a very good position to get rid of the type, or to reverse that pre-diabetes or to improve those markers unless you do the other things as well. Does that make sense?
Yeah, absolutely. I think it's also a thing of trajectory of how you're going over time. So in the same sense that, look, if you're 18, you're massively overweight and your health markers are perfectly fine. You're an A+ specimen on the biopanel. There's nothing.
Which is like every 18-year-old, by the way.
Yeah, literally.
Doesn't matter what you do. Like,
yeah, that's a really massive argument of healthy at every size, because like, okay, cool, everything's fine, but it's not the fact that like obesity by itself, as like if I spent a day being overweight, this is significantly overweight, that everything's going to start crumbling down. Exactly. It's that progressive every single day of every hour of every second. Your body is facing this inflammatory response. It's facing additional problems that it can't normally cope with. exactly like the type 2 diabetes, where you're having an excess inflammatory response, you're not providing enough nutrients to your cells throughout the body, as well as a bunch of different other pathways. Obesity is still one of those areas where we're still studying, we're still understanding why and how it does all these negative things to the body, and how can we address this. The new medications are absolutely a step in the right direction, but it can be very tricky using them in an adequate response, especially when we're not getting the correct pathways of going to see a dietitian, going to see an exercise physiologist, going to get those additional supports along the way. So it's an area of very interesting, very complicated, but it can be very simple for the methods and remedies that we put in place. Just a quick ad break. We're now currently taking clients by the link in the description or via our website. Back to it.
I reckon a really good way to not really an analogy, but a really good way to process this information, if you are someone that wasn't super keen on learning about the physiology behind of why being overweight for a prolonged period of time is bad for your health, if you just think of like, if you put on a 50 kilogram backpack, or not even that much, a 30 kilogram backpack every day, do you reckon you're going to develop arthritis quicker or later than, if you didn't do that, and like have, when you hurt yourself, it's going to be that much, when you, injure yourself, it's going to be that much worse, or like, whatever it is, from like a injury point of view, rather than like a, cell point of view. I think it's much easier for people to contextualize it. Like, yeah, damn, if I was carrying around a 50 kilogram backpack on my back the entire day, I can imagine my knees and my ankles and my hips would get pretty beat up pretty quickly. And it's kind of like the same for your body. Like it's like you can wear a 50 kilogram backpack for a day or even a year, probably be fine. You might just get a little bit stronger, but
absolutely.
Decade after decade of doing it and then getting into old age, that's when you start to realize like, damn, my knees are killing me, man.
I think that's also a factor of, look, if you're carrying an extra 50, 60, 100 kilos on your body, the likelihood that you're going to engage in daily activities and have a higher non-exercise activity thermogenesis is going to be reduced. And as we know, with things like arthritis, you use it or you lose it. Unless you're actually moving those joints and moving around that fluid that makes sure that they're lubricated and it's providing those tissues with enough lubricity to keep them without grinding on each other, it can be really tricky to maintain the health of those joints. And you kind of have, again, inactivity tends to lead to a lot of problems, can increase rates of arthritis and things along those lines. But of course, if it's genetic factor, different story. On the topic of genetic factors, type 2 diabetes has a genetic predisposition. You're more likely to get type 2 diabetes if you have a family history of it. But I think this often gets confused with type 1 diabetes because they're very separate genetic, let's say, predispositions. Max, can you take me through that a little bit?
Yeah. So essentially, you need to have a gene to have type 1. Wait, am I getting confused with celiac?
No, you have to have the gene for type 1, yeah. I'm 90% sure.
Yeah.
You have to have some genetic abnormality.
But I know for celiac, 100% you need to have a gene, that's for sure. But for type 1, pretty sure you have to have a gene. So it means that like literally you could get yourself genetically tested and you can determine whether you have the proclivity to get type 1 or not. And then usually it's some sort of an event, and that event can be more or less in severity depending on, I guess, what happens in your life. It could be you could get really sick and then all of a sudden your body sort of, that gene's activated, I guess you could say. And the autoimmune disorder starts attacking those cells. And usually it is some sort of big event in your life that activates that gene, and then you are a type 1 diabetic for life, and that's it.
It can be a progressive thing as well, but usually, yeah. And sorry, it's multiple genes.
Sorry. Yeah. Cool. Whereas the type 2 is a little bit more nuanced in the sense that type 1 is quite black and white. It's very easy to understand, very easy to conceptualize, and it's probably a good basis to start learning about diabetes, because then you can get your head around those basic things like the pancreatic beta cells, insulin, all those words that you can transfer to learning about type 2. So it's a really good place to start if you want to learn about diabetes, would be learning about type 1 because it's so simple. And then type 2 is a bit more of that nuanced element. So for example, the reality is with genetics, everyone has very different genetics. For example, I've seen patients where, and this is a lot more nerdy talk, but patients with a really, really high HbA1c, which is essentially what that is your blood glucose, the average blood glucose over a prolonged period of time. They had a really high HbA1c. Matthew was like, the percentage was just insane, and it ended up being like he had a average BGLs of like 30 or something like that. It was just
wow,
stupid.
how is he alive?
Just crazy.
Wow.
Just insane.
For context,
And,
I think diabetes aiming for under 7 is considered good diabetic management. For most people, under 6.5, the diabetes cutoff is 6.5% IFCC, I think, from my memory.
Right, yeah, sure. And this person, I won't give away too much information because it's probably quite sensitive, but this person in the situation that I was in at the time, we'd known this person for a long time. So this wasn't like a once-off of like, oh, his last 3 months or last 6 months have been pretty bad. This was like a known thing. This dude's is like this, and just because of the situation in his life, I'll leave it at that. But basically, he was doing pretty much everything wrong to do, like if you wanted to prescribe someone to get chronic kidney disease and for his EGFR to drop, you would essentially do what he's doing, right?
Oh, no.
This dude's kidney function was crazy good. Over 90, just consistently. Insane, right? And so what does that tell me? Now, of course, this is an N=1 study, so it's just stupid, right? But
yeah,
this is backed up by evidence anyway, so I'm happy to talk about it. People have different rates of proclivity to develop diseases.
Yeah.
This dude's kidneys were built out of like carbon fiber, like sun.
Actually, like titanium kidneys. Yeah, unstoppable. Wow.
Insane kidneys.
I get those. They're cool.
Unbelievable, right? This dude's just never going to develop CKD ever. It's just like not going to happen. Yeah, he was relatively elderly, not old, but like relatively elderly. Just he's not going to develop CKD. I mean, it doesn't matter what you do. And the reality is there would be people out there who just have people that really, really low inclinations to develop type 2 diabetes, no matter what you do. They could be obese their whole life. They could never do any activity whatsoever. They could just eat literally lollies all day long, and they'll be fine. They'll manage. They got really, really, their insulin doesn't get resistant. Their pancreatic beta cells are just absolutely fine. Just no issues whatsoever. And that can just happen with people. So I guess the point of me saying this is that there's the reverse to that, in the sense that you can do very little, unfortunately, and have a really high proclivity to develop these issues. And that's what we see. There's obviously anywhere in between the two extremes.
It's a bell curve. You're going to have some people at the opposite, where it's like, hey, never even thought about diabetes and have all the kind of environmental factors. And then you got the complete opposite, where exercise plus managing the muscle mass plus low body weight plus pretty much doesn't eat any carbohydrates at all, and you're going to have developed type 2 diabetes. And it's like you would almost be excused for like a type 1 diabetes in that kind of situation, but it's a different but majority of the people, if we're looking over that kind of the standardized bell curve, it's you're going to be fitting into that kind of general 3 specific environmental factors.
Exactly. Yeah, so I guess that's my point. So this is a very, very long-winded answer, but I thought it was relatively interesting anyway, giving you the little story. But it's essentially explaining what type 2 diabetes is just how likely you are to incur all the things that come along with developing type 2. So, how likely is your body to become insulin resistant? That's going to be very different from person to person. How likely is your pancreatic beta cells to die? Like, what's the word? Just to destruct,
quote,
to die.
Burnout. Yeah,
burnout. Yeah. Like how likely is all these things to happen to you? It's so there's a lot of nuance to it, and it really depends on your genetics. So whilst it's very easy to look at type 1 and be like, well, that's the genetic type of diabetes, and type 2 is the self-inflicted one or whatever it is. There's a lot more nuance in that, in the sense that, well, like people can't really control their weight anyway, and there's a lot of things that are out of people's control, like their hunger levels and all that. So it's definitely not purely self-inflicted. There's a lot of things that they're at the whim of their genetics.
Absolutely. Of the population, I would say it's a very small minority. I think majority of the individuals are like at the whim of those 3 main environmental and lifestyle factors. But it's definitely an interesting thing to have a conversation about. I think it's really great. So you mentioned previously, Max, just had a thought of the acute nature, of the short-term nature of a high stress situation of any number of different organ systems, you mentioned like the heart, the pancreas, the burning out of the pancreas. I think you got to liken it to having some short-term stints of something is perfectly fine, like exercise, perfectly fine. Having the occasional glass of alcohol is perfectly fine. You could argue a little bit, but going through an extended period of, let's say, you have a little bit of an injury, but it's a short-term injury, generally you're going to recover relatively okay. The bruise kind of tends to fix the problem on its own. But when you have an extended, chronic, more, let's say, tricky situation, I think I would almost liken it to liver damage with extended intake of alcohol or drugs or something similar, where the liver cells get exposed to that higher level of toxins and they need to process so much over an extended period of time. I would almost consider that a very similar level of burnout, where it's the cells are dying because they've had to overwork and they've had to try to fix the damage that's occurring and provide a remedy for the body at the expense of their own cells. And you can almost do the exact same thing. It's, look, exercise can be really, really beneficial, but if you've gone from zero exercise to running a marathon the next day and you've never trained for it before and you haven't fueled properly and you have a predisposition of having heart tremors and arrhythmias and things like that, then absolutely exercise can kill you in these kind of instances. But that's going from 0 to 100. People generally don't do that. So it's almost like comparing those two situations wouldn't be realistic or applicable at all. I mean, look,
Yeah.
that's just a little bit of a thought that was on my mind. I'm sorry to steer the conversation in a different way.
No, it's really interesting. So yeah, because it is interesting to think about that. You know, for example, like with the kidneys, right? Because like with the heart, I think that's a really interesting example in the sense that it's very good to do things that use your heart a lot. You know, to go for a run, things that are, you know, it's very cardioprotective. You know, to do things that involve cardiovascular endurance,
specifically because it adapts to the stimulus after.
Yeah. But then doing things like being obese, for example, which elevates your heart rate significantly, or, you know, there's doing things that where your heart rate is chronically elevated, not good at all. You know, something that's not something that's conducive to long-term health outcomes, to positive long-term health outcomes. It's really interesting. Like, is it the same for, and I don't know, is it the same for example, your kidneys? Is it good to do little spurts of using the kidneys a lot, or is it best? Is less just best? Like, always less is best.
I think the kidneys are such a delicate topic because they are so delicate. Thanks to the nephrologist, the single nephrologist that's listening to this podcast. They're such a complicated organ as well that I don't know if they have an adaptation response that would be, let's say, measurable or worth exploring in the same sense. It's like, oh yeah, I'm going to have one meal that's super high sodium to spike my blood pressure for a little bit, and then it's going to be like, I'm going to go back to my low sodium diet. Probably fine. Your kidney is going to cope and rebound from the potential damage that would have occurred. The more, let's say, tricky situation is that chronically exposed high blood pressure over that extended period of time, or potentially low blood pressure in some cases. But it's more so that without that acute small time response, the more chronic responses don't allow for an adaptation of our body, and we can't exactly give it that, I guess, positive health stimulus that we're looking for. I don't necessarily think the kidneys can adapt to that. I'm not entirely sure if the liver can either. I think the brain probably can. Muscles, absolutely. That's probably my main one that I would be thinking of. This is a little bit.
That's awesome, and that's what we're going to bounce off to next podcast. I haven't even ran through this with you, but I'd love to. We're going to be having a chat about sodium and the whole idea of, you know, sodium increases your blood pressure acutely, and whether that's a myth or true, and how sodium impacts the body and exercise and sports. Because something's really interesting and something both Matt and I are super passionate about. So. Jumping off from the kidneys, just like we'll talk about it, that's what we'll be discussing in the next podcast. Matthew, to finish off, I think we started wanting to talk about today about, can you reverse type 2 diabetes? And we never even discussed it in the whole 55 minutes we've been talking. Let's give a brief summary. You know, I'm not sure how long you'll need for it. I only need a couple minutes. In my opinion, reversing type 2 diabetes is, again, a blanket term for a complicated topic. In the sense that the answer is maybe. You know, how long have you had the type 2 diabetes for? How damaged are the pancreatic beta cells? Is it to a point that it's like, well, no, you just, it's impossible to reverse it because there's nothing to work with here. do you just have pre-diabetes? You know, because the whole thing of pre-diabetes is like, that's when you can really kick into gear. You know, like that's a really good reason of why we have pre-diabetes, to kind of give you that warning of like, alarm bells are going crazy right now. We need to change big time. So the answer is maybe. And that it sounds like a cop-out answer, because as like kind of the answer for everything, but it really depends on so many things. You know, how much has the diabetes progressed in your body? How much are you willing to put in the work? Because the reality is, it's like, because if you've got type 2 diabetes, especially if you've known about having pre-diabetes for several years beforehand, the chance you're likely to put in a whole lot of work to change it is probably pretty low, because you probably would have done that during your pre-diabetes phase, you know? So there's so many factors that are at play here, which is going to really depend on how much can you reverse it and what reversal actually looks like. You know, reversal isn't a black and white term either. You know, it could be just you're improving. You know, you're having to use less insulin, or you're having to manage it less times per day, or whatever it is, changing the type of insulin you're using. You know, that's still improvement, but it's not necessarily 100% reversal.
Yeah, absolutely. I can't disagree at all. I think you've made a really great point there. I like to liken it to a situation of that I commonly get is, hey, can I lose weight and build muscle at the same time? And the answer is yes, but it's only in certain types of populations, generally untrained individuals or potentially deconditioned athletes who have had an injury and they need to come back to the point where, yeah, absolutely. I can't disagree at all. You can reverse the severity of the type 2 diabetes 100%. Absolutely, you can reduce the severity without a doubt. Whether you can reduce the long-term damage that you've done to your pancreatic beta cells, but not only those cells, but the cells in the rest of your body in terms of its ability to be sensitive to insulin and accept insulin as a messenger molecule, as a hormone, it's tricky. It's very tricky. The earlier you can get in, the better. It's an investment. You're looking at getting yourself out of debt. Can you get yourself out of debt? The longer you're in debt, the worse it gets. It's one of those tricky situations. If you look at it from a financial perspective, very simple. You want to pay off the debt as quickly as you possibly can. That's the pre-diabetes stage. That's when you've taken out a credit card, you've taken out a little bit too much, and it's like, oh, look, I really should pay this back. Paying that back, usually in the green, you can go below the pre-diabetic level towards like a normal, quote, normal HbA1c, blood glucose level. But if that credit card starts to spiral, and now you've taken out another loan, and now you've taken out another loan on your mortgage, and now you're in debt beyond what the mortgage is capable, now you're sinking, now you're bankrupt, bye-bye, kick the bucket. Getting in early is incredibly important. Managing your carbohydrate intake throughout the day, managing the sources of GI, the sources of carbohydrates to lower GI sources, increasing your physical activity to the point where you're gaining lean muscle mass as much as possible and supporting that lean muscle mass integrity through adequate nutrition strategies, and reducing your total overall weight to a point where it's acceptable and your lean muscle mass is much higher than the percentage of total adipose tissue, are all massively incredible and massively important aspects of type 2 diabetes management and type 1 diabetes. But that's a whole separate conversation to have.
Yeah, no, 100%, man. 100%. And I love that analogy. I think that analogy works awesomely for the debt and all that, because it's like, you know, just really quickly, you could think of eating different foods could be like doing, putting in more hours at work and doing more activity, like finding a second job and starting, starting the, taking out your first loan to help with the mortgage could be like maybe starting Ozempic or starting a, drug, and then like defaulting or going bankrupt could be like literally starting insulin, and like that's it. Like you can like literally expand that pretty well. I like that analogy a lot.
Yeah,
that's cool.
Definitely an interesting topic. Absolutely. The medication fits into this pretty well. Your doctor will work more closely with you for your medication management. Often metformin is one of those kind of implementary first stage things. Just be aware of your B12 levels, because sometimes it can be reduced from metformin's just use. It tends to be a little bit of a tricky drug to manage, but just keep on top of those from an annual blood test. For other medications, I'll leave that in your GP or your specialist's hands. We're here for the additional support that you need from overall lifestyle recovery, exercise, lifestyle, and overall nutrition strategies that can support you within this situation. And look, it doesn't have to be hard. You can make it easy enough to where it fits into your lifestyle. You don't need to flip everything upside down. Even doing one of the 3 environmental factors and focusing on one of those can make absolutely huge results moving forward, and potentially even reduce the type 2 diabetes if you've gotten in early enough and if those implemented strategies are effective enough.
Yeah, for sure. And look, the reality is that, and this is trying to, sell dietetics as a whole, which I think dietitians are generally pretty good at, to be honest. There's a lot of diseases where dietetics and dietitians are used in conjunction with a lot of other professionals. Heart, for example, with with heart attacks, probably if you didn't have surgeons, we probably wouldn't have any heart attack patients to work on, because they'll be dead because they didn't have stents and stuff like that. It's you need to work with a lot of other disciplines, with pretty much whatever it is that you're doing, you need to be working in collaboration with other disciplines. With type 2, the dietitians are we're definitely not the sole person that you work with. You're going to work with a lot of other people, but we're the main person you work with. This is our field and our area, and there's not many of them, whereas this is our space for dietitians. So I would really, really strongly suggest work with a dietitian if you're in this phase. Don't working with the doctor's fine, but go with the experts here. And there's a reason why when you have a heart attack, I'm not saying go see a dietitian. I'm saying go see a surgeon to get something. When you have cancer, don't go see a dietitian. Go see a surgeon to get the cancer out, or to get your chemo.
As a primary goal, it's you go see the person that's the most important. Then everything trickles down. Then of course you can see an oncology advisor, and go see a counselor, and go see a dietitian to support. Look, when you start into malnutrition territories, I think that the importance of a dietitian becomes even more important. But I 100% agree that diabetes is a huge factor, and the primary intervention should be a dietetics management strategy, as well as exercise physiology and potentially some other factors in that scenario, because we're the experts in providing strategies that work with your life. Because any random doctor can say, hey, you need to cut out X, you need to do Z, you need to just blah, 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 just do it. And that saying has never worked for anyone. I'm surprised Nike even still uses it. It's just, it's trash. It's trash. Work with what your habits are. And we're looking at those long-term, really positive habitual changes that we're aiming towards. Those really important behavior changes. Because in some cases, we're working against 60 years of habit formation, which can be very difficult in some instances. And it can be very overwhelming, as absolutely, without a doubt. Just telling someone, hey, cut out this food, it's not going to cut it.
Yeah, no, 100%. Yeah, so that's all my recommendation would be. Work with a dietitian, preferably work with a dietitian who is an expert and specializes in the field of diabetes. They're all gonna know their stuff. They're all gonna do a good job. But someone that, especially if they specialize in the field of diabetes, boy, they're gonna be good, and they're gonna have the experience and know their stuff. Because someone who isn't specializes in it, someone who's just, maybe they specialize in cancer or something else, they're still gonna know what to do, because you know the physiology and you know how to treat it, and you know. You've learnt it before, and you know the information, but you potentially don't have the experience of that. You've dealt with hundreds or thousands of clients with diabetes, and you know what works and what doesn't work. So absolutely. That's my little spiel of because I think it is cool. It is cool to acknowledge that this is our space. We can kind of sit in this space and be this is our area.
For those long-term
There's not many
changes,
we get to say that for.
Absolutely, that's true. Oh, look. You could almost argue that cystic fibrosis is one of them.
Yeah.
Cancer, late stages of cancer, absolutely. You're looking at your osteoporosis is definitely one of them as well. Malnutrition, huge one. Weight management, absolutely. I think those key important factors are a huge one. Sports nutrition is such a huge one, which I think is undervalued in the field, which is quite interesting. I think athletes often go by vibe and placebo versus evidence, which is very interesting. Very, very interesting.
Yeah. I think just the things with especially with sports nutrition, because I agree with what you said there. We're always seen as the secondary or the third or
a supplemental role, which is quite interesting.
Yeah, exactly. And that's fine. You don't get into dietetics thinking you're going to be, the super king role. But it is cool to also recognize when we do own our spaces.
Absolutely. Thanks, Max. That was a great chat. Bye.
Peace.
Thank you so much for listening to the R.E.A.L Health and Nutrition podcast. The sponsor of today's show is you. You support the show by listening and using our services of dietitian consultations and performance coaching. We offer in-depth one-on-one consultations to help you achieve your health and performance goals. Any random bloke online can give you a generic meal plan where we here at R.E.A.L work collaboratively with you to reach your goals, making you feel heard and including you in your journey's planning. Our service offers tailored advice and can accompany meal plans and or realistic nutrition strategies, which can be booked via our website, www.recoveryexerciseandlifestyle.com. That's www.recoveryexerciseandlifestyle.com. Just a quick disclaimer, this podcast is for education, information, and general entertainment purposes only and does not constitute the practice of medical nutrition therapy or healthcare of any discipline. The content discussed in this podcast is not intended to be a substitute of professional medical advice, diagnosis, or treatment. Please review our terms of use via our website. Thank you so much, everyone. Have a great day.